and that is Saima Ashraf. So she's a senior clinical research nurse from the rash and the genetics team over at the City campus. Over to you, Saima.
Thank you very much. Let me just share my slides, and my camera might go away. Right, okay. Hello, everyone. As Lindsay introduced me already, I am Saima Ashraf, and I am currently working as a research nurse in CAS, where I do cover quite a few specialties. I am actually studying second year of my PhD, which is part-time with collaboration of NUH and NTU, Nottingham Trent University. So, oh, I didn't even share my slides, did I?
Are you all right? Can you do it?
Yeah, I think so. I should. President team. It is saying President Teams, yes. So I should have got ready about this one. It's connecting, sorry.
That's okay, don't worry.
Let me just quickly ask Jack if he can.
Do you want me to share?
Do you know how? Because there's a slightly change on slides, that's the problem. Or shall I send it to you and then you can share? I just need to share these slides. How can I?
You want to show them?
Yeah,
Yeah.
I tried this. It's not happening.
Share.
Oh, okay. Yeah.
Hey, there we
Yes,
go.
yeah, great. Thank you very much, boss.
If you do it as slideshow, then we'll see in full screen.
Yes. Is it better now?
Not yet, just along the top where you've got file and home. If you go along to where it says slideshow, that's it, just across. Keep going, keep going, keep
Oh,
going.
yeah.
That's it.
Yeah.
And if you click that,
Yeah.
and then from beginning. That's lovely.
Yes.
There we are.
OMG,
Thank
there's
you.
a lot of learning today.
That's okay.
Right, okay. So so as I says, I am actually studying my PhD, and I am looking at heart failure induced by antipyretic and nonsteroidal anti-inflammatory drugs. I will give a brief introduction why I chose this topic. So heart failure, we all know, heart failure is life-threatening syndrome, and it can significant impact on mobility and mortality, poor function capacity, and quality of life. Currently, we have 64 million people globally and almost 1 million people in UK with heart failure. Therefore, attempts to decrease its social and economic burden have become a very major global priority in public health. I am looking at paracetamol and ibuprofen. So I have started looking at paracetamol. I would say all of us have a paracetamol in our kitchen cabinet. However, in overdose situation, it can lead to renal and hepatic toxicities, which can, of course, impact on cardiac complications, which is not reported on research out there. There's a lot of papers out there for renal and hepatic failure or toxicities, but not on heart failure. And regards to ibuprofen, we had well, it is very controversial basically with the NSAIDs. 50% of research papers are saying it is impacting on heart failure, and other 50% are saying it is not really impacting and it's safe to use. So that's where I am. My argument will be it is not really safe to use over the counter, or buying over the counter, and using, especially with the community and nursing homes and residential homes, where the patients or community hardly have a blood test. So we can basically, we can't really measure the safety for over the counter having a paracetamol and ibuprofen. So my aim of study is, in this work, my aim to find a correlation of heart failure, which is based on NHS statistics and literature. A lot of literature, I would say. I have read 100 plus, probably more than, papers, and overuse of NSAIDs and antipyretic. And we are investigating the cardiovascular safety of NSAID and estimate the risk of hospital admission for heart failure with use of individual drugs. And another aim will be to assess risk of hospital admission for heart failure and use of individuals NSAIDs such as paracetamol, ibuprofen, and diclofenac as well. So the translate learning into practice, why I'm doing it, and how that's what I've told you why I'm doing it, but how we can learn into practices. I believe through my research, I am to identify how these medication impact patient beyond clinical trials, because of course we had a clinical trials on NSAIDs and on antipyretic, but that was like 100 years ago for paracetamol and around 70 years ago for ibuprofen, because ibuprofen was invented in 1969, so it's not really far if we could see. And then particularly in terms of safety, heart failure, renal function, and hospital readmissions, this will help inform more individuals and safer prescribing practices. My goal is to bridge the gap between researchers and clinical care, ensuring that patients receive treatment that are not only evidence-based practice, but also practical and effective in real-life settings. So it won't be like kind of, it will be on papers, but on real life setting, people are just doing what they want to do. Of course, they can do what they want to do, but of course we need safety measurements with this. So this will lead to reduce hospital admissions, improved quality of life, and better overall patient outcomes. And then I'm looking at, I feel like, I am in unique position to translate these findings directly into practice. So I can contribute to improve patient education, because as a researcher, we are seeing a lot of participants. So we can give them, support them, educate them, and identify early sign of deterioration. So that was my aim for this study. Next slide will be on methodology. Sorry if it's too chemistry based, because I am working with the chemistry thing. So on this, you could see I have prepared crystals, calcium carbonate crystals with a chemical called DEAE dextron. So, and then I did on my experiments, I did stir two different speeds. One was 100 RPM and another was 650 RPM to see if the calcium carbonate crystals are taking crystals loading with the dextron. So which, as you can see, all these green shiny stars, basically this is calcium dextrane. It is into the crystals. So that was my first experiments, because I wanted to be perfect on those before I will load with the drugs, with the paracetamol and with the ibuprofen. So as you could see, it is actually taking into crystals, the dextron on different speeds. So, and then I would have, so this was my um, scheme, basically. I was going to say regime, scheme. So I have taken, this is a paracetamol loading to calcium carbonate. So I have taken 100 nanomilliliter paracetamol with calcium carbonate, and then centrifuge into 100 rpm, and then then I observe if under the microscopic if the crystal have taken the calcium carbonate, so which was taken. But and then after this whole experiment, I've left the crystals for 18 days on room temperature, and then observe them again and see there was still crystals present, but they lost their integrity and there was no a proper shape or size for crystals. So with the support knowledge embedding across the team will be we will be ensure that new knowledge and learning are actively shared. So when I will have my whole data, the findings, of course I will share with my teams and with R&I, and it will integrate into teams practices so that they enhance existing workflow, policies, and projects. This involves communicating insights clearly, encouraging collaborative discussion, and identifying practical ways to apply new information in day-to-day work. Of course, it is a long journey, but when I will find my findings, we will take it from there. And then by supporting colleagues to understand and adopt new approaches, help promote consistency, improve the quality of practice, and ensure that learning leads to meaningful and sustainable improvement across the teams. So with the strengthening to collective capabilities will be contribute to building shared expertise across the department by sharing insight and practical knowledge gained from cases such as heart failure potentially induced by paracetamol and ibuprofen. And then discuss clinical observations, risk factors, monitoring strategies, and management approaches with colleagues to reduce knowledge and increase collective confidence in applying accredited learnings, and then encourage collaborative reflection on such cases, highlighting how careful medication review can be, and patient assessment and interdisciplinary communication can prevent advanced outcomes. So these are basically I'm looking at how we can take it from. Of course, it needs to go through a lot of ethics and a lot of well, I would say everything, but yeah, that's what I'm looking for. So from my project, I am looking at how I can return investment in training is the dose response relation between NSAIDs dose and heart failure risk will be assessed. Estimate of the risk of heart failure associated with the use of many individuals in SAIDs will better inform clinicians, health regulators, and the general population, our largest stakeholders. The information collected by this will be educate and empower individuals to manage their health and well-being. And it will promote patient self-management and independency to help reducing future readmissions. This can lead to reduction in other treatment costs for comorbidities. For example, treatment costs for hypertension, diabetes, ischemic heart disease, atrial fibrillation, and chronic obstructive pulmonary diseases. And then it can decrease the hospitalization, will create more bed being available for emergency care or planned operations, which will have a positive impact on reducing crowding in A&E. NUH will then read these newly available resources in other areas, such as hiring staff to improve care quality. And applying new knowledge might reduce medication errors, improve monitoring of high-risk conditions, enhance patient experience, or streamline study requirement and data collection. So this is so far I am doing. Thank you so much.
Wow, thank you so much, Simon, for sharing your insights and for such a clear and practical overview of how you've applied your accredited learning in your role. Has anybody got any questions for Simon?
I think it's Rakesh, yes.
Rakesh, do you want to go?
Yeah. Hi. Can you hear me?
Yes.
Yes.
Thank you very much, Simon, for this brilliant presentation, and best of luck for your PhD. I have a couple of questions. Like, paracetamol has been in use for more than 100 years, as you mentioned, and ibuprofen for about 40, 50 years.
Yep.
And they are over-the-counter medicines to relieve pain. I agree that in case you are able to link the OTC usage of these NSAID drugs, link them to the heart failure, would definitely, if the link turns out to be positive, can lead to reduced hospital admissions and better quality of life for the patients.
Yeah.
But on the other hand, if the link is positive, as your question suggests, what about the quality of patients who are unable to kind of buy these drugs for mild to moderate pain in their day-to-day, like infections and inflictions, like whatever, headache, arthralgias, and so many other things, dental pain. And the GP practice is already overburdened. You have to have, sometimes the appointments are not given to you for days together, for minor ailments. If the patient are unable to procure a simple thing like a paracetamol or ibuprofen over the counter,
Yep.
won't that be counterproductive as far as the quality of life of the patients is concerned? That was my kind of concern.
Yes, it's a really good one, I would say, because of course, even though I am I am raising this question, but right now I have paracetamol and ibuprofen both in my kitchen shelf, I would say. Of course, because we need it. But I am looking at if my project, once I'm done with the lab, the next part is surveys and questionnaires. So it's just I'm trying to raise awareness basically for it. And if we could have, of course, ibuprofen and paracetamol, if we wanted, or on the prescription, that's going to impact even more financially to NHS or GPs. However, if we could have some kind of measurement where the people are buying paracetamol or ibuprofen like over the counter, if we could have those measures in place, so we will know, because at the moment I have searched quite a lot, but we do not have any regulation about it, how if the people are buying 10 of pack paracetamols, right? So if we could have something in place, so we will know if how many people have using the paracetamol and ibuprofen. So probably we will have in the future, we will collect the data and we will say, okay, so people are using more paracetamol or ibuprofen because paracetamol is harmful for the heart, but of course we don't have evidence yet. However, with ibuprofen, we clearly have evidence, as I mentioned, it is 50%, it says it is impacting. So it's not just impacting on heart failure, it is impacting on on our kidneys, it is impacting our liver, it is impacting young girls with the infertility, it is impacting on GI bleed, acutely bleed, upper GI bleed. So it is basically impacting a lot of things, especially NSAIDs, ibuprofen and diclofenac. So if, as you said, mentioned, the people are taking ibuprofen, if we are, they are taking ibuprofen, but can we have some kind of measurement? Like, in pharmacy, if we can, say like, okay, so we, of course, it will be difficult. Actually, I am trapping myself into it. It will be difficult to measure how the people are taking ibuprofen if I will go now and I will go next day to say, okay, I need a ibuprofen again. But we do need a kind of, some kind of measurement. I do not have an answer right now, to be very honest, how we can, do that. But yes, but definitely ibuprofen is not very safe how we are thinking it is safe to use. And I would say, like, probably you guys will aware of it. Ibuprofen, well, NSAIDs won't even, when it was invented, it wasn't even for pain. It was coincidence when the Adam, who is inventor of the ibuprofen, pharmacist, was in Boots in Nottingham, basically. He was the one he was a drunk and he did not have anything so he can control his headache. So he thought, okay, I will have what I am preparing. So he had that ibuprofen, which he was actually in the middle of inventing, and then he had it, and then pain was disappear. So since we are using for pain, for headache, or for, but we don't know the consequences are what we are dealing with. I know it's not my, perfect answer, but I'm just trying to justify my question, actually.
Okay, thank you. If you stop sharing your screen now, if you're done with it, we
sorry.
will be able to see your face also.
Okay, yeah. You just stop now, right?
Thank you.
Thank you. Okay, I think Zoe Rose has got a question.
It's more an observation. So at the moment, everybody's sort of limited to the amount of paracetamol they can buy in one go anyway, which for those people who take paracetamol purely for pain is quite annoying already. I think, is it 16 you're allowed to buy in one go now? So if you're taking paracetamol 4 times a day, 8 a day, that's 2 days worth.
You can buy 32.
Can you?
And in some chemists, you can buy 2 packs of 32. I have done that.
But for those of us that shop at supermarkets, shove a packet in the trolley as we're walking around, knowing full well next week someone's going to have a cold or whatever. And as was said before, if there's not paracetamol on ibuprofen, what is there for that lower level of pain? And also the fact that for children as well, paracetamol is used very commonly to reduce symptoms of infections such as a temperature. And what's the risk versus benefit? That's what I'm trying to get to, because obviously if you've got a child with a temperature that you cannot reduce with anything other than NSAIDs or paracetamols, you're then risking that child convulsing. So is there a sort of a comparator that you're going to be looking at?
Yes, I would be. As I says, after my lab work will finish, I'm going to go to clinicians for surveys. For clinicians, nurses, GPs, that is part of my project, and of course the population community as well. So, and then I would have a little bit more insight about it. Yes.
Are you? Do you have a PPIE group?
For this one?
Yeah.
I haven't had it yet because I am not doing it yet, but I do need ethics and everything when I will start.
Okay.
Yeah, because that will be starting my after 3 years, basically, because I'm part-time. So I still have like 3 years left. So it will be after a year now. Then I will go for PPI and everything for ethics, and this it's all it's all listed. But yeah, because currently I am just doing lab work, just to check in. So I don't really need it right now, because I'm just doing in NTU, not in NHS yet. But when I will come to NHS, then I would need all of these.
And you know where to come.
Yes.
I shall see you in a couple of years.
Oh, yeah. Probably next year.
Yeah. The earlier, the better.
Yeah. Yeah, because it does take time, isn't it?
Yeah.
It does take quite a long time, basically. Yes.
Thank you.
Thank you.
I'll go next if that's okay. I was just going to ask you why the research evidence, you were saying it could be quite controversial and sort of 50% say, yeah, it's fine, and 50% say, no, it's not. Is it just because it goes so underreported, or because it's hard to monitor when people self-medicate? What leads those two extremes of evidence?
Yes, it is hard to monitor, basically, because we are not sure, as I keep mentioning, how many people are having it, and especially with the community, and especially with the nursing homes and with residential homes. Once they do have ibuprofen or paracetamol on their prescription, there is hardly, because I was used to work in nursing home, and I do know how they work. There is hardly they will see any bloods or anything. The repeat prescription will be on and on and on and on for few years, basically. So that's why we don't really have. So there's no measurements at all. So if we do have an overdose of paracetamol, we all know it needs a treatment for it. But if the people are using, I have seen so many patients where it says, oh, I was in tooth pain, I was having a tooth pain, toothache, and then I've used paracetamol and it wasn't working. I've taken another one. So they do go over 4 grams quite often, basically. So yeah, there is no measurement at all for now. And with the trials, because there's no measurement, there is with the trials, there is a lot of trials, like official trials who is looking at the safety of using it. I couldn't find a lot of. It always says there's a controversial. Mostly it says it is not impacting, but yeah, that's why. Does it make sense?
Okay. Yes. Yeah. Okay. Thank you. Rakesh.
Yeah, I would like to endorse what Zoe said about, febrile convulsions conditions. So this is something like in the middle of the night, if your child gets fever, so it's always, it's a nightmare for the parents to run around just to get a prescription for a paracetamol suspension. And especially if the child starts convulsing because of the fever and febrile convulsion status, it can be a real panic, and all the more difficult for single parents. So I really do not know what to say. Of course, the risk may be associated. There are side effects of each and every drug, including paracetamol and ibuprofen. But then, as somebody in the chat, Zoe, I think, mentioned that there are, yes, of course, it comes down to risk versus benefits. So we cannot totally eliminate paracetamols, ibuprofens, and such NSAID drugs altogether from the counter. And of course, there has to be some other way to control these prescriptions. That's just my thought. Thank you.
Well, I'm hoping on that. Sorry. Yeah, go on.
No, it's fine.
Yeah. Well, I was going to say, I'm hoping on that, there is a possibility I won't find anything. So there's finding says it is not impacting and we will be as it is, how we are. So at least I will have an answer to my question, which I do have, and where when I was reading the literature and I was like, oh, okay, there's a lot of controversial stuff over there. So we could have a look on that. So there is a possibility I won't find anything, and then we will be fine with that.
Yeah, I think we're all sort of looking on the negative side, aren't we? And that might not be the outcome.
Maybe it is, okay, it isn't impacting. All right, okay, my 5 years will be gone.
And I guess even if it's still used and used as often, I think just highlighting that something actually is potentially harmful and maybe it limits the the contraindications for patients, or just makes people more aware of long-term use and maybe change overall practice. So like you were saying about maybe proper reviews for patients who have chronic pain or have that written up as just a regular prescription and isn't so far monitored. Anything that highlights the long-term risks can only be good for everybody, can't it?
Yeah, definitely. Yes. And
Fantastic.
we all know there is every medicine have a side effects. We do know. Otherwise, pharmaceutical company will be shut by now.
Exactly.
So there will be side effects for every medicine. So yeah.
Brilliant. Thank you. Has anybody else got any questions before we move on? No? Okay. Thank you so much, Simon. That's great.
Thank you for having me.